Okay, now we're going to discuss common endocrine disorders. Hyperpituitarism, or acromegalia, page 1157. Often occurs because of benign growth hormone secreting pituitary adenoma, which is just basically a benign tumor formed from glandular structures in the epithelial tissue. Excess growth hormone causes an overgrowth of soft tissues and bones in the hands. Bones of the arms and legs do not grow longer, so you'll have excess tissue in these areas, but like the hands won't, the fingers won't get longer, the arms won't get longer with it. The clinical manifestations, or the signs and symptoms, are going to occur over a period of time and may go unnoticed because there's such a gradual change with it. There's thickening and enlargement of the bony and soft tissues of the face, feet, and hands, and there's going to be a tongue enlargement that result in dental problems with it. The tongue enlargement is going to, like I said, is going to cause dental problems, which is also going to result in speech problems with it. The voice is going to deepen due to hypertrophy of the vocal cords. Visual changes may occur due to pressure of the optic nerves from the pituitary adenoma, and headaches are very common with this. Growth hormone antagonizes the action of insulin, glucose tolerance, and manifestations of diabetes. It's the thing to remember, it's a rare condition. 4 out of 1 million adults in the U.S. are diagnosed annually. So it's very rare. It'll affect both genders, usually diagnosed between ages of 40 to 45, and life expectancy is usually decreased by 5 to 10 years. Okay, so this is what I was talking about. That you can see the pictures of this lady when I was talking about the clinical manifestations of acromegalia. You can see the first picture in 1977, how her face is shaped, and by 1981, you can see it's starting to kind of change and to have more, especially around the forehead and the nose nose area. And by 1988, you can see a really big, the last picture, you can see a really big change. You can see that she kind of looks like the same, but her face has kind of almost changed shape with it. Over here, the gentleman on the slide, he is the actor that played in, if you're a big James Bond fan, he was in the earlier James Bond movies with it. So, but you can tell by the shape of his face that he has soft tissue growth and stuff like that on it. So he is one of the more famous ones, I guess you could say, with this diagnosis of it. And the pictures of the hands are showing what a hand with acromegalia looks like and what a normal hand looks like. It's just a comparison. So, with diagnosing this, they're going to do a very thorough history and physical to see, as if there's been changes and complications with some things like a headache, problems with their vision. They're also going to then draw some labs. They're going to evaluate. They're going to do an evaluation of the plasma insulin-like growth factor, your IGF-1 levels, and the values are going to be based upon age and sex. Remember, I talked in the drug book. It's your lab manual, you're going to have it broken down by sex, age, race in them. So this is one of them that they will do that with. Growth response to oral glucose tolerance test, your OGTT test. And as the growth levels rise, what they're looking for is an increase in the IGF-1 levels, because as the growth hormone levels increase, this level will also increase with it. The next thing that they're going to do is to look for the pituitary adenoma. So they're going to do an MRI or high-resolution CAT scan with contrast, and then they're going to do an eye exam. So once this person has been diagnosed with it, the treatments are going to be medication-wise or surgical. They're going to administer a dopamine agonist such as bromocriptine to help decrease the tumor size. They're going to do surgical removal of the pituitary tumor. They may do radiation, either external or with a gamma knife, to help reduce the adenoma size if they can't remove it. Hormone replacement following surgery if they do remove it, to help compensate with things. And then they're going to administer antihypertensives. Okay, so continuing with the treatment of this disease, acromegalia, drug therapy is going to be used in combination with surgery, or they're going to use it in a combination along with radiation therapy. The drug that they're going to use most commonly is called sandostatin. It has a synthetic hormone, and it works to decrease the amount of growth hormone and return it to normal levels. So one of the things that you're going to need to do is patient teaching. Before using, you're going to check the product visually for any discolor, because it's an injection. You're going to make sure that there's no particles or discoloration that are present. If they are, you do not use the liquid. And before injecting each dose, clean the injection site with rubbing alcohol. And you're going to rotate this injection site with it. This medication, sandostatin, is usually given by injection under the skin, usually 2 to 3 times a day, or as directed by the doctor with it. So this isn't just something that they're going to be able to get maybe once and they'll be done with it. It's going to be something that they get up to 3 times a day. And depending on the condition, it may be given by injection into the vein by a healthcare professional. We can give it IV, but typically the most common way for sandostatin to be given is, intradermally with that. Okay, this is just another mnemonic for hyperpituitaryism for acromegalia. Hypopituitarism can be found on page 1158. Excuse me. It's a rare disorder which involves a decrease in one or more of the pituitary hormones. The most common hormone deficiency associated with hypopituitarism involves growth hormone and gonadotropins. The cause of pituitary hypofunction is caused by a pituitary tumor. So anytime that you see anything with the pituitary gland, you're going to see, it's going to excrete too much or not enough. So it's an autoimmune disorder. Autoimmune disorders, infections, and pituitary infarctions are destructions of the pituitary gland. African Americans have a higher incidence of pituitary adenoma than any other ethnic group. An anterior pituitary hormone deficiency can lead to end organ failure. Deficiencies of the TSH and ACTH can lead to death. With the deficiency of the ACTH can lead to an acute adrenal insufficiency and hypovolemic shock from depletion of sodium and water in the system with it. So manifestations. You're going to have fatigue due to decreased ACTH production. You're going to have, because of the lesions where the pituitary gland is, you're going to have visual disturbances because it's going to take up so much space. You're going to have headaches due to the location of it, loss of smell also. And then you're going to end up with nausea and vomiting, decreased appetite, and unintentional weight changes due to the thyroid stimulating hormone deficiency. You're going to have also menstrual irregularities and shorter stature because of decreased or diminished or totally decreased secretion of the growth hormone. They're going to diagnose it using an MRI and CAT scan to identify the pituitary tumor. Labs are going to do your thyroid test to see if there is a decrease in it. So your TSH, your T4 and T3 are going to be decreased. Your cortisone or your ACTH stimulating test, is going to be decreased. So what they're looking for is a decrease in your lab levels. So your thyroid, your ACTH, your prolactin, and your growth hormone production are all going to be decreased. So management is going to be surgery or radiation. They're going to try to either shrink it with radiation or remove it through surgery. A hypophysectomy or surgical removal of the pituitary gland. That's what it's called. So post-op with this, you're going to monitor for a hematoma compressing the optic nerve, any changes with vision. You're going to monitor the visual acuity. You're going to do an assessment on them like we did with your head-to-toe assessment on checking the visual acuity, ocular movement, pupillary responses. You're going to also educate the patient to report any visual changes immediately. Monitor for complaints and persistence of severe generalized or supraorbital headache, which may be an indication for cerebral spinal fluid leak. You're going to elevate the head of bed at all times at 30 degrees because you don't want them laying flat, because that's going to cause a shift with pressure on that. And general oral care for 10 days post-op to prevent sutures from being tore out. So you're going to maybe have them swish and spit. You're not going to let them get in there with an electric toothbrush and just vigorously brush their teeth, because they're going to have sutures up on the roof of their mouth area. So with this, the treatment for it is going to be lifelong hormone therapy. The growth hormone, corticosteroid, thyroid hormone, and sex hormone. You're going to maybe give them different types of different types of hormones to help replace it. They might be on Synthroid with it, hormone replacement therapy. The women are going to be on estrogen and progesterone replacement therapy, just to treat like the hot flashes and stuff with it. And testosterone is going to use to help men with hypogonadal issues once they have the pituitary, because remember, this is all with the growth hormone and stuff that help regulate some of this like hormonal levels, like estrogen and stuff in the body. Here is another little mnemonic to help you with hypopituitarism. Okay, hyperthyroidism, or Graves' disease. You can find this on page 1163 in your textbook. Hyperthyroidism is an abnormal thyroid gland overproduction of your T3 and T4. Hyperthyroidism is hyperactivity of the thyroid gland with sustained increase in synthesis and release of your thyroid hormones. It occurs in women more than men, with the highest frequency in persons between the ages of 20 and 40 years of age. It can be caused by autoimmune disease, such as in Graves' disease. It's a benign tumor causing a goiter, which is swelling of the throat, in the throat area around your thyroid. Inflammation, pituitary tumor. Graves is the number one associated with the autoimmune disorders due to the destruction of the thyroid tissue. It's the most commonly known one. Rheumatoid arthritis, pernicious anemia, systemic lupus erythemia, or SLE, Addison, celiac, and vitiligo are also part of this disease. So the most common form of hypothyroid disease is Graves' disease. It accounts for 75% of the cases with it. Graves' disease is greater than 90% of the cases of hyperthyroidism in younger adults. It's an autoimmune disease, and its hypermetabolic state. Women are 5 times more likely than men to develop Graves' disease, and it's due to insufficient iodine supply, cigarette use, infection, and stressful life events. The term thyrotoxicosis refers to the physiological effects and or clinical syndrome of hypermetabolism, which is a result from excessive circulation of the T4 and T3, or both of them together. And hyperthyroidism and thyrotoxicosis usually do occur together. Graves' disease is an autoimmune disease of unknown etiology characterized by diffuse thyroid enlargement and excess thyroid hormone secretion. In Graves' disease, the patient develops antibodies to the TSH receptors, or your thyroid-stimulating hormone receptor. These antibodies attach to the receptors and stimulate the thyroid gland to release T3, T4, or both of them simultaneously. Graves' disease accounts for up to 75% of the cases of hyperthyroidism. Women are 5 times more likely than men to develop Graves' disease. And precipitating factors such as insufficient iodine supply, or cigarette smoking, infection, stressful life events may interact with genetic factors to cause Graves' disease. The disease is characterized by remission and exacerbation with or without treatment, which means it'll go into remission and it may come out and they may start having some symptoms and some issues with it, with or without treatment. So it doesn't matter if you're taking thyroid medication or not, you're still going to have issues with it coming in and out of remission. It may progress to destruction of the thyroid tissue ultimately causing hypothyroidism. Graves' disease is associated with the presence of other autoimmune disorders, including rheumatoid arthritis, pernicious anemia, SLE, Addison's disease, celiac disease, and vitiligo. The clinical manifestations of hyperthyroidism are related to the effect of the excess circulating thyroid hormone. It directly increases metabolism and tissue sensitivity to stimulation by the sympathetic nervous system. This is why with hyperthyroidism you're going to see an increased metabolism. You're going to see a lot of weight loss with it. Palpitation of the thyroid gland may reveal a goiter, which means you may see swelling around the thyroid gland. When the thyroid gland is excessively large, a goiter may be noted on inspection. So some people, you might see a little bit of it, and some people you may see kind of like a big swollen area on their throat where the thyroid gland is. Anterior common findings in ophthalmopathy, and I know I've mispronounced that word. This is an abnormal eye appearance or function. This is kind of where the eyes look like they're bulging out. So exophthalmos you can find on page 1162. This is increased pressure which forces the eyeballs outward. The upper lids are usually retracted and elevated with a sclera visible above the iris. When the eyelids do not close completely, the exposed corneal surfaces become dry and irritated. Serious consequences such as corneal ulcerations and eventual loss of vision can occur. The changes in the ocular muscles result in muscle weakness causing diplopia. On that, they can fix this, they can correct that with surgical procedure, going in and I believe it's where they reinforce the muscles to help pull them back in with that. Clinical manifestations that affect the cardiovascular system and respiratory system. You're going to see, with respiratory, you're going to see dyspnea upon mild exertion. You're going to see an increased respiratory rate. They're going to have a respiratory rate that is like usually in the upper 20s sometimes when they're just resting, not doing any exertion. Also, the cardiovascular system, you're going to see systolic hypertension. You're going to see bounding rapid pulse, palpitations, systolic murmurs, dysrhythmias, due to this. Remember, due to the increase of the thyroid stimulating hormone that is being released in the body, or your TSH. Okay, GI manifestations and integumentary. GI manifestations of hyperthyroidism includes they're going to have increased appetite and thirst. They're going to have the weight loss because their metabolism is working so high. They're going to have increased peristalsis, bowel sounds. They're going to tend to have diarrhea. The clinical manifestations with the integumentary system include they're going to have warm, smooth, moist skin, thin, brittle nails detached from the nail bed. They're going to have hair loss. It may be kind of patchy, or they may have really thin hair. They're going to have clubbing of the fingers. They're going to have really fine hair with premature graying in men, diaphoresis, vitiligo, and they're going to have pubertal myxedemia. Okay, with musculoskeletal manifestations, they're going to be tired, fatigued, they're going to have dependent edema, they're going to be more prone to osteoporosis. On the the effects on the nervous system are they're going to have nervousness, they're going to have a fine tremor of their fingers and or tongue. They may have one or the other or both. Insomnia, they're going to be exhausted because they can't sleep. They're going to have personality changes, they're going to be irritable, they're going to be agitated, they're going to maybe suffer from depression. They're going to have a lack of ability to concentrate. Okay, patients may experience irregular menstrual periods. They may have decreased libido. The men may be impotent. Gynecomastia in men. Women are going to have more of a difficult time becoming pregnant. This is where usually you'll see women with hyperthyroidism are going to be receiving maybe fertility help to help them become pregnant. Other clinical manifestations might include they're going to be hot all the time, so they're going to be intolerant to heat, elevated basal temperature, their eyelid retraction, and they're going to have rapid speech. Their body is just running on high. It's just running full speed all the time with hyperthyroidism. So acute thyrotoxicosis, or it's also known as a thyrotoxic crisis or thyroid storm, is an acute, severe, and rare condition that occurs when excess amounts of thyroid hormones are released into the circulation. Though considered a life-threatening emergency, death is rare when treatment is initiated early. It is the result of stressors such as infection, trauma, or surgery in a patient with pre-existing hyperthyroidism. Patients undergoing a thyroidectomy are at risk because of manipulation of the hyperactive thyroid gland results in an increase in hormone release. So this is why if you have somebody in for a thyroidectomy, you're watching them for, thyrotoxicosis or a thyroid storm. So manifestations of acute thyrotoxicosis or a thyroid storm are severe tachycardia, heart failure, shock, hyperthermia. Their temperature will be above 106 degrees Fahrenheit. Agitation, delirium, seizures, abdominal pain, vomiting, diarrhea, and coma. So if you see any of this in a post-op patient that has had something surgically done to the thyroid, this is a medical emergency and you need to recognize it, especially with the temperature. So if you see somebody and you're monitoring their vital signs and you're starting to see their temperature elevate, you need to notify the PCP and let them know so you can be on top of that. Okay, so hyperthyroidism diagnosis. So inspection and palpation of the thyroid gland, goiter may be noted, auscultation may reveal bruits. So you're going to listen with a stethoscope on a goiter to hear if you can hear that bruit sound. Abnormal labs they're looking at for hyperthyroidism is TSH is going to be decreased or undetectable. You're going to have an elevated T3 and elevated T4. Your LDLs are going to be decreased. With that, the RAU test is used to differentiate Graves' disease from other forms of thyroiditis. The patient with Graves' disease will show a diffuse homogeneous uptake of 35% to 95%, whereas the patient with thyroiditis will show an uptake of less than 2%. The person with a nodular goiter will have an uptake in the high normal range with that. They'll also do they'll do ECG to see if they're having what their heart rate is doing, and then also a thyroid scan will reveal the enlarged thyroid. Okay, drugs are used in the treatment of hyperthyroidism, and they include antithyroid drugs, iodine, and beta-adrenergic blockers. These drugs are useful in treating thyrotoxic states, but they are also not considered curative. Treating Graves' disease in people over 50, radioactive iodine therapy is used to decrease the thyroid production. Surgical removal of thyroid gland if it interferes with swallowing and or breathing. And patients are at higher risk for osteoporosis and should be receiving screening as ordered by the PCP. Now, nutritional therapy is going to be important because since they have such a high metabolism and they're burning a lot of calories, they're going to need a high-calorie diet, 4,000 to 5,000 calories per day, which is 6 full meals, not like 3 meals and 3 snacks. It is 6 full meals with snacks in between. They're going to have a protein intake of 1 to 2 grams per kilogram ideal body weight, increased carbohydrate. They're going to need to supply fuel to the body. Avoid highly seasoned and high fiber foods, caffeine, and definitely refer them to a dietitian. Okay, now we're going to discuss hypothyroidism. Hypothyroidism can be classified into 2 different categories, primary or secondary. Primary hypothyroidism is caused by destruction of the thyroid tissue or defective hormone synthesis. Secondary hypothyroidism is caused by pituitary disease with decreased TSH secretion or hypothalamic dysfunction with decreased thyrotropin releasing hormone secretion. Hypothyroidism can be transient and related to thyroiditis or discontinuing thyroid hormone therapy. after the thyroid has been removed. Iodine deficiency is the most common cause of hypothyroidism worldwide. In the United States, the most common cause of primary hypothyroidism is atrophy of the thyroid gland. The atrophy is the end result of Hashimoto's thyroiditis or Graves' disease. The autoimmune disease has destroyed the thyroid gland. Hypothyroidism may develop after treatment for hyperthyroidism, specifically after a thyroidectomy. Drugs such as amiodarone, which contains iodine, and lithium, which blocks hormone production, can cause hypothyroidism also. Hypothyroidism that develops in infancy, which is creatinizum, is caused by thyroid hormone deficiency during fetal or early neonatal life. All infants in the United States are screened for decreased thyroid function at birth, and you'll get more of that in maternal child. Regardless of the cause of hypothyroidism, it has systemic effects characterized by slowing of the body process. Where hyperthyroidism, where everything is sped up, hypothyroidism, everything has slowed down. Manifestations vary depending on the severity and the duration of thyroid deficiency, as well as the patient's age at the onset of the deficiency. Symptoms may develop over months to years unless hypothyroidism occurs after a thyroidectomy, thyroid ablation, or during treatment with antithyroid drugs. So the patient is often fatigued, lethargic, experiences personality or mental changes, including impaired memory, slow speech, decreased initiative, and somnolence. Many appear to be depressed. There's going to be weight gain. It is most likely as a result of decreased metabolic rate. This is why if you have weight gain, and you're trying to follow a diet and regimen and you just continue to gain weight, a lot of times they will run a thyroid test on you to see where your thyroid levels are. Hypothyroidism may cause significant cardiovascular problems, especially in persons with previous cardiovascular disorders. It is associated with decreased cardiac contractility and decreased cardiac output. Thus, the patient may experience slow exercise tolerance and shortness of breath upon exertion. Increased serum cholesterol and triglyceride levels and the accumulation of the multipolysaccharides in the intima of the small blood vessels can result in coronary atherosclerosis. So on a patient with hypothyroidism, you're not only going to see some respiratory issues where they're going to be short of breath, and it could be due to the excess weight that they've gained. It also could be due to fatigue and some of the other issues going on with them because of the low thyroid levels. So on the neurological system, you're going to see the fatigue when you're assessing them, and you're going to see lethargy, personality and mood changes, impaired memory. They're going to have a slowed speech, decreased initiative, and somnolence with it. And the biggest complaint that you're going to see when you take care of somebody with hypothyroidism is they feel like they just never ever get enough rest, and they just don't feel like their mind is as clear as it used to be. So some of the continuing of the clinical manifestations of hypothyroidism: the GI system, you're going to have a decreased appetite, nausea, and vomiting. They're going to have a weight gain even though they're not eating a lot. It's because their metabolism has slowed really down quite a bit. Constipation due to slow metabolism, distended abdomen, enlarged scaly tongue, celiac disease. The skin is going to be dry, thick. It's going to be cold. They're going to have thick, brittle nails. Their hair is going to be like a horse's tail. It's going to be really coarse hair. It's going to be very thin. It's going to be, you're just going to look at it and it's going to look like, it just basically looks like the horse's tail. It's where it's really rough. It's not soft and fine and stuff. It's more coarse texture. Poor sugar, generalized intestinal edema, puffy face. They're going to have decreased sweating, and they're also going to have pallor with it. With the musculoskeletal system, like I said, you're going to see fatigue and weakness, muscular aches and pains, slow movements. The reproductive system, they're going to have prolonged menstrual periods or amenorrhea, decreased libido. There's going to be infertility with it. So even with hyperthyroidism, you're going to, which you see infertility, you're also going to see it in hypothyroidism. You're also going to see increased susceptibility to infection. They're going to be they're going to have an increased sensitivity to opiates, so it's going to take a lower dose to maybe, you know, get the reaction out of them that typically would. Barbiturates, anesthesia. People with hypothyroidism tend to not respond well to anesthesia. It takes them a little bit longer to come out of it. Intolerance to cold. They can't take the cold. Decreased hearing, sleeplessness, and they will have a most all of them will have a goiter with this. So patients with severe long-standing hypothyroidism may develop myxedemia, which is the physical appearance of the skin and subcutaneous tissue. Myxedemia is due to an accumulation of hydrophilic mucopolysaccharides in the dermis and other tissues. This edema will cause puffiness, facial and periorbital edema, and a masked lack of fat. Individuals with hypothyroidism may describe an altered self-image related to their disabilities and altered appearance. They really don't like looking at themselves, and as you can see in the picture here, you know, they just really have a kind of like their eyes are kind of like saggy with bags. It just is like a mask-like appearance with it. Mental sluggishness, drowsiness, and lethargy of hypothyroidism may progress gradually or suddenly to a notable impairment of consciousness or coma. This situation, termed myxedemia coma, is a medical emergency. Myxedemia coma can be precipitated by infection, drugs, especially opiates, tranquilizers, and barbiturates, exposure to cold, or even trauma. It is characterized by subnormal temperature, hypotension, hypovolemia. Cardiovascular collapse can result from hypoventilation, hyponatremia, hypoglycemia, and lactic acidosis. For the patient to survive a myxedemia coma, vital functions must be supported, and IV thyroid hormone replacement must be administered. So, the test results under the diagnostic studies is you're going to have an increase in TSH, where hyper you had a decrease. Your T3 and T4 in hyperthyroidism was increased, but hypo is going to be decreased. Presence of thyroglobulin indicating Hashimoto's thyroiditis. Cholesterol levels are going to be increased. They're going to have anemia. Creatine kinase are going to be, their CK is going to be increased in this. So the treatment for this is hormone replacement. Levothyroxine is going to be the most commonly one that you see. Serum measurements of your T3 and T4 will need to be performed after 6 to 8 weeks to determine and to ensure the proper dosing. Education of patients need to include this this is a lifelong therapy. And if you look on page 1170 at table 49-11, this kind of will help you with it. But the biggest thing you need to stress with them, that this is going to be a lifelong therapy. They're not going to just take the medication and then all of a sudden their thyroid is going to start working and they can stop the medication. This is a lifelong therapy with it. This is a side-by-side comparison of hypothyroidism and hyperthyroidism. Just kind of it just makes it easier for you to compare and to see the differences of them a lot easier. Okay, continuing on with endocrine disorders, we're looking now at the parathyroid glands. Hyperparathyroidism can be found starting on page 1171. Hyperparathyroidism is a condition involving an increased secretion of the parathyroid hormone, PTH. PTH is responsible for helping regulate serum calcium and phosphate levels by stimulating both reabsorption of calcium, renal tubular reabsorption of calcium, and activation of vitamin D. Primary hyperparathyroidism affects 25 of 100,000 persons per year. It is classified as primary, secondary, or tertiary. Primary hyperthyroidism is due to an increased secretion of PTH leading to disorders of calcium, phosphate, and bone metabolism. Most common cause is a benign tumor of the parathyroid. Patients who have undergone head and neck radiation have an increased risk of developing a parathyroid adenoma. Long-term lithium therapy has also been associated with it. Women are twice as likely as men to develop it, and it usually occurs between the ages of 40 and 50. The peak incidence is when usually the peak incidence of hyperparathyroidism occurs. Secondary hypoparathyroidism is a compensatory response to conditions that induce or cause hypocalcemia, the main stimulus of PTH secretion. This condition includes vitamin D deficiency, malabsorption, chronic kidney disease, and hyperphosphatemia. Tertiary occurs when there is hyperplasia of the parathyroid glands and a loss of negative feedback from circulating calcium levels. Complications range from asymptomatic to a patient with overt symptoms. Signs and symptoms of hypoparathyroidism. They're found on page 1172. The patient may be asymptomatic. They may have increased serum calcium levels, which will be seen in lab work. Bone pain or a fracture as a result of excreting calcium from bone. Kidney stones, frequent urination due to increased calcium in the urine, blurring of vision owing to cataract formation with it. The manifestations are associated with hypercalcemia, typically loss of appetite, constipation, fatigue, emotional disorders, shortened attention span, and muscle weakness in the extremities are also often noted. Complications include osteoporosis due to the leaching of the calcium from the bones, renal failure, like I said, kidney stones, vertebral fractures, anything, since this is pulling out calcium from the bones and it's not being replaced as rapidly as it should, is going to cause problems with it. So this is where you see a lot of fractures that they could be walking or they couldn't be doing any, they could be just sitting there or just move wrong, and it can cause a fracture sometimes with it. So to diagnose it, they're going to run labs, and when they're looking at it, you're going to see serum calcium is going to be increased, serum PTH is going to be increased, the alkaline phosphate is also going to be increased. Your serum phosphorus will be decreased, urine calcium increased. They're going to also do a thyroid scan to see if an ultrasound to see if a tumor shows up, fine needle biopsy of the parathyroid tumor, and they're also going to be doing bone density testing just to see if there's fractures, and they're going to be doing these labs, but also they can do a bone density test while they're waiting for lab results to come back to kind of see where the bone, how thick the bones are and stuff. The main treatment is going to be surgical removal of the parathyroid tumor, administration of biphosphonates to lower serum calcium levels by increasing calcium absorption into the bones. They're going to dilute the serum calcium by doing IV normal saline. They might put them on a diuretic to help excrete calcium from the urine better. And if asymptomatic, monitoring of blood levels and symptoms. So if you're going in for like a routine lab and you're seeing your serum calcium, your PTH are all elevated, but you don't have like any fractures, you're not having any kidney stones, you're not showing any of the main signs and symptoms of it, what they'll do is they'll maybe put you on furosemide to help excrete the calcium in the urine, but just also monitor you until you start developing symptoms, and then they may do something different as far as looking at maybe administering a biphosphonate to help lower the calcium. So a lot of it is depending on if you're symptomatic or asymptomatic. Hypoparathyroidism. This is a rare disease, very uncommon. It is caused by diminished function of the parathyroid glands, which is associated with the inadequate circulation of PTH in the system. If there is a lack of PTH in the system, or sufficient enough PTH in the system, the patient may and usually does develop low calcium and elevated phosphorus levels with it. The primary cause is there is a destruction either accidentally or due to something else that's going on with them to the glands during a neck surgery, like with a thyroidectomy. The clinical features of acute hypoparathyroidism are due to hypocalcemia. So if you have like a sudden decrease of calcium concentration, it can cause tetany, which is characterized by tingling in the lips and stiffness in the extremities with it. So, continuing on, signs and symptoms of it. Due to the hypocalcemia in the system, like I said, it's going to cause muscle cramps, muscle spasms, or tetany, which is also muscle irritability when you're looking at what tetany is, which is caused by your abnormal levels of calcium. There's going to be, with tetany, you'll see tingling of the periorbital area, hands and feet from the low levels of calcium. The person will have lethargy owing to low levels of PTH. They'll have cataract development. They'll have convulsions due to low levels of calcium. So think about, anytime you think about hypoparathyroidism, think about decreased calcium levels, and that kind of will lead you towards, okay, what are some of the signs and symptoms? What's happening to the body when you don't have enough calcium in it? Continuing on with the diagnostic tests and treatment. Diagnostic tests are going to be lab work. So now, as we have gone through these diseases, I'm hoping that you're kind of looking through your lab manual and kind of trying to find these to see, okay, this is what the serum calcium level is supposed to be. You need to become familiar with doing some of this. So your diagnostic tests are going to look at your serum calcium, your serum PTH, and your urinary calcium. Those are all going to be decreased, where your serum phosphate is going to be increased in it. You're going to have a positive Trousseau sign, which is a carpodial spasm caused by inflating you're going to put the blood pressure cuff on, and you're going to inflate it to the level above systolic pressure, and it's going to sit there for you're going to hold it for about 3 minutes with that. The other thing is, you're going to be monitoring their ECG also with it to see what their heart rate is doing, especially when you start administering and doing the treatment part of replenishing the calcium on it. So the treatment is going to be initiate seizure precautions due to low calcium, puts you at a higher risk for seizures. Administering calcium gluconate by IV via slow drip. Oral calcium, you're going to be sure it's going to be either like calcium gluconate, lactate, or carbonate, and you're also going to give them a low dose of vitamin D. Now, whenever you give calcium, and you need to remember this, is that you need to have calcium with vitamin D, because vitamin D will help with the absorption into the bones and stuff with it. So when you're educating them, tell them to look for calcium with vitamin D, and that will help with the reabsorption. Otherwise, calcium is just not going to be absorbed like it needs to, and it's going to be excreted out in the urine. Aluminum hydroxide gel or aluminum carbonate gel to decrease phosphate levels, and high calcium, low phosphorus diet. So you're going to be doing a lot of things as far as trying to treat the low calcium levels, or counteract the low calcium levels with it on the treatment part of this disease. Addison's disease, which is an adrenal cortical insufficiency. You can find this starting on page 1178 in your textbook. This is caused by inadequate secretion of hormones for the adrenal cortex, your glucocorticoids. They help control glucose, suppress the immune responses, aid in stress response. Mineral corticoids, they aid in electrolyte balance, androgens and estrogens resulting from some damage to the adrenal cortex. They're like an autoimmune destruction, tuberculosis. These cause a destruction of the adrenal gland and are the two main causes of Addison's. Hemorrhage or tumors are also possible causes with it. Surgery or other stressful events may result in a decrease in the production of the cortisol and of the aldosterone. Fungal infection, AIDS, and metastatic cancer have also been linked to this. Addison's crisis is a medical emergency, and 80% of Addison's in the United States are caused by autoimmune response. Tuberculosis is the most common cause worldwide, although it is not seen in the U.S. When we talk about the autoimmune response, we're talking about autoimmune adrenalitis, which causes the adrenal cortex to be destroyed by antibodies. This will result in the loss of the glucocorticoids, the mineralocorticoids, and adrenal androgen hormones, which I just talked about at the beginning of this slide. Addison's disease can be present along with other endocrine conditions, and this is known as an autoimmune polyglandular syndrome. It is most common in white females. Those with autoimmune adrenalitis often have other autoimmune disorders such as type 1 diabetes, autoimmune thyroid disease, pernicious anemia, and celiac disease. So, with Addison's disease, signs and symptoms are not going to show up really until 90% of the adrenal cortex is destroyed, and that is usually when it is more in the advanced stages. Weakness, fatigue are usually the first symptoms that they usually start seeing, and this is usually due to insufficient cortisol in the system. There's going to be weight loss, loss of appetite, nausea and vomiting, and lesions of the oral mucosa. They will also develop orthostatic hypotension. Bronzing of the skin is due to hyperpigmentation. Now, one of the most well-known people is John F. Kennedy. He had Addison's disease, and if you go back and you look at pictures of him as the disease progresses throughout, especially you see it throughout his later terms of his pregnancy, you start seeing he's getting more and more and more of the bronzing effect with it. So maybe that, if it helps you to put a face to a disease process, think Addison's disease, John F. Kennedy. So complications with Addison's, the patients with adrenal cortical insufficiency are at risk for acute adrenal insufficiency or an Addisonian crisis, which is life-threatening emergency caused by insufficient adrenal cortical hormones or a sudden sharp decrease of these hormones. So this is usually brought on by either stress, example from infection, surgery, psychological distress, the sudden withdrawal of corticosteroid hormone therapy, which is often done by a patient who lacks knowledge of the importance of this therapy, adrenal surgery, and a sudden pituitary gland destruction with it. During the acute adrenal insufficiency, the patient exhibits severe manifestations of glucocorticoid and mineralocorticoid deficiency, which is where you see the hypotension, tachycardia, dehydration, hyponatremia, hyperkalemia, hypoglycemia. Hypotension may lead to shock. So with that, you're seeing a circulatory collapse associated with the adrenal sufficiency, and is often usually unresponsive to the usual treatment like your vasopressors and fluid replacement on that. So, like I said, if you start seeing somebody that has Addison's and they start showing like tachycardia and hypotension, weakness and fever, you definitely want to make sure that the doctor knows about that. You also want to teach the patient to notice these symptoms so that they can let the PCP know also, so they can be treated. So, diagnostic testing. You're going to be looking at the blood urea nitrogen, your BUN. It's going to be increased. Your serum potassium is going to be increased. Your serum cortisol, remember it's a deficiency of it, is going to be decreased. Your serum glucose is going to be decreased. A positive 24-hour urine aldosterone level. A positive adrenocorticotropic hormone or ACTH stimulation test. They're also going to do an MRI and a CAT scan to see if there's an abnormal adrenal gland or tumor on it. ECG may show low voltage and peaked T waves. During the treatment, you're going to administer cortisone or hydrocortisone, administer fluorocortisone to help regulate sodium and potassium, maintain a fluid balance, and additive salt substitutes in hot, humid days, because they're going to have hyponatremia a lot of the time, so you need to replace that salt. Cushing's syndrome, it is found on page 1174 in your textbook. Okay, Cushing's syndrome is a clinical condition which results from chronic exposure to excess corticosteroids, particularly the glucocorticoids. There are several conditions that can cause Cushing's syndrome, but the most common cause is an iatrogenic administration of exogenous corticosteroids. Remember when we talked about diabetes, we talked about exogenesis. We're talking about steroids given outside the body. This is something that's added on, that we give externally. Looking at, like your prednisone. About 85% of the cases of endogenesis Cushing syndrome are due to an ACTH secreting pituitary adenoma. With it, so Cushing's disease and primary adrenal tumors are more common in women in the age group between 20 and 40. Ectopic ACTH production is more common in men. If you look in your book on page 1175, table 49-13, you're going to see manifestations of adrenocortical dysfunction. On the left side, you're going to see Cushing's, and on the right side, you're going to see Addison's disease. We're talking about Cushing's right now. So with the things with Cushing's disease, there are some very common characteristics that you're going to see. The general appearance, they're going to have truncal obesity, thin extremities, rounding of the face, we call it a moon face, fat deposits on the back of the neck and shoulders, which give them the buffalo hump with it. So if you look down and figure 49-11, those are what common characteristics of it. You're also going to see on the abdomen, they're going to have what we call a purple striae. It looks like stretch marks. Ecchymosis resulting from easy bruising. They're going to have slow wound healing. They're going to have glycosuria, risk for kidney stones. They've got muscle wasting in the extremities, fatigue, osteoporosis. They're going to have a very awkward gait. It's going to be kind of like more of a stiff gait. With that, there's marked sodium and water retention edema on that. They're going to have possibly acne, hyperpigmentation. They may have like red cheeks. They may have thinning of hair. They may have acne where they've never had acne before. So the Cushing's has got, remember, Addison's has the bronzing of the skin from hyperpigmentation. With Cushing's, they've really got more of a distinct body appearance to it. They're going to have that truncal obesity. They're going to have really thin arms. They're going to have a really rotund belly. But they're also going to have the moon-shaped face. So, diagnostic tests and treatment. So, diagnosing Cushing's begins with confirming elevated plasma cortisol levels. There are going to be 3 tests that are used. You're going to do a midnight or late night salivary cortisol. You're going to do a low-dose dexamethasone suppression test and a 24-hour urine cortisol. The urine cortisol level is higher than normal, in the normal range of 80 to 120 micrograms per 24 hours, indicate that they have Cushing's syndrome. You're also going to look at your plasma ACTH levels. They may be low, normal, or elevated depending on the underlying cause of the Cushing's syndrome. High or normal ACTH levels indicate Cushing's disease, where low or undetectable levels indicate an adrenal or medical etiology. Other findings on your diagnostic tests are going to be associated with, but not necessarily a true diagnosis of Cushing's on that. So, but you're going to have maybe a blood glucose, which is going to be increased. Your potassium is going to be decreased on that. So, by themselves, it doesn't say, okay, your blood glucose is increased and they're not really having anything else show up on these other tests. Does not necessarily mean Cushing's with it. So, your dexamethasone suppression test is probably going to be the first one and the most commonly used one to diagnose them. Treatment: surgical removal of a pituitary tumor or adrenal tumor. They're going to do radiation treatment targeting the pituitary tumor, especially if they're not a surgical candidate. And they're also going to do cortisol replacement if it's necessary during recovery with it. So this means that they're going to be taking a lot of medication sometimes to treat this disease with it. But remember, the primary goal of treatment is to normalize the hormonal secretion. The specific treatment is going to just really depend on the underlying cause and what is the reason the person is developing has developed this disease. So now we're going to just quickly go over some of the types of surgeries that they will use for treating these diseases. So thyroidectomy, you find that on page 1166. This is indicated for those who have a large goiter causing tracheal compression, lack of response to antithyroid therapy, thyroid cancer. It may be indicated for those not a candidate for the radioactive iodine therapy. The surgical procedure, which involves removing 90% of the thyroid, and may be done endoscopic or by robotics, like the Da Vinci arm. So, subtotal thyroidectomy is a treatment of choice. If you look at the figure on figure 49-8 on page 1166, you'll see where the before picture shows you the larynx, the trachea, and the thyroid, and you see that butterfly shape of the thyroid. When you go in and do a subtotal thyroidectomy, you remove one side of it. They like to do this because it leaves part of the thyroid there. They're going after removing part of the thyroid that's not working, that has maybe the tumor on it, but leaving the other, which kind of leaves the body the ability to produce some of the thyroid hormones with it. So it is, like I said, it is really the treatment of choice. They want to keep as much thyroid intact as possible with that. So prior to surgery, they're going to give them antithyroid drugs, iodine, and beta adrenergic blockers to help achieve the body to achieve the feeling of the what we call eurothyroid state, which means it's like the body thinks, okay, we've got all this stuff in our system, the thyroid must be functioning right. They really will prefer to also give iodine, which helps reduce the vascularization of the thyroid gland, thus reducing the risk for hemorrhage. So, some of the complications that you're going to see is hypothyroidism. If they end up removing all of the thyroid, it's going to you don't have thyroid hormones being produced in the body, so you're going to end up having some thyroid issues, such as hypothyroidism. Damage to or inadvertently removal of the parathyroid gland, causing hypoparathyroidism and hypocalcemia. Remember where the parathyroid is. It's right there next to the thyroid. Hemorrhage due to the vascularity of it. Injury to the recurrent or superior laryngeal nerve, which can also cause laryngeal stridor, which is a harsh vibratory sound. And this may occur during inspiration and expiration because of the edema to the laryngeal nerve. Thyroid toxicosis, infection, difficulty with breathing due to swelling of the neck tissue. So what you're going to do is you're going to assess the patient every 2 hours for 24 hours for signs of hemorrhage or tracheal compression, assess for irregular breathing, neck swelling, choking, blood on the dressing. Some of the hoarseness there's going to be some expected hoarseness for 3 to 4 days after the surgery due to the edema from the trauma of the surgery with that. Adrenalectomy. You can find this procedure on page 1176 of the textbook. This is indicated for Cushing syndrome caused by adrenal tumors or hyperplasia. It's a laparoscopic approach used unless there is a malignant adrenal tumor is suspected, and they'll go in and they'll do it open. Open surgical adrenalectomy is usually performed for the adrenal cancer with it. Patients with ectopic ACTH secreting tumors, they are the best managed by locating and removal of the tumor with that. So a hypophysosectomy is the surgical removal of the pituitary gland. It is the treatment of choice for tumors in the pituitary area, especially smaller pituitary adenomas. Most surgeries are done by endoscopic transphenoidal approach, and you can see that on page 1159, figure 492. When the entire pituitary gland is removed, there is a permanent loss of all pituitary hormones. The patient will require a lifelong replacement of therapy of the thyroid hormones, sex hormones, and glucocorticoids. Radiation therapy can reduce the size of the tumor before surgery, and that's usually what they will do with it, is that they'll go in, they'll give them radiation to shrink the tumor so it's a little easier to remove and there's a little less damage to the area. So, there are 3 different ways that they can remove the pituitary gland during a hypophysectomy. You can do it either transphenoidal hypophysectomy, which is where they go through the nose into the sphenoid sinus, which is a cavity near the back of your nose. They can do an open craniotomy where they remove the pituitary gland through an opening in the front of your, which is in the front of, from under the front of your brain through a small opening in your skull. There's a stereotactic radiosurgery, which is where through small openings in the skull, they will go through and they will do instruments on the surgical helmet, place it through the hole openings in your skull, and then the pituitary gland of tumors are then destroyed using radiation to remove specific tissues while preserving the healthy tissue around them. This procedure is usually done on smaller tumors. Now, post-operatively, you're going to assess the patient for formation of a hematoma compressing the optic nerve. You're going to monitor peripheral vision, visual acuity, extraocular movements, and pupillary response. You're going to monitor for cerebral spinal fluid leaks and epistaxis, which is nosebleeds, and other common postoperative complications. It is usually one of the things that the surgeon might do is they may place a petroleum jelly-coated ribbon of gauze or a balloon-tipped catheter, like an indwelling urinary catheter, in the sphenoid sinus, and it is usually removed after 24 hours. It can be left in for 2 to 3 days if there are any concerns of bleeding or cerebral spinal fluid leak. It is important that the patient does not blow their nose for at least 48 hours after the surgery and avoid vigorous coughing and sneezing and straining at stool to go to the bathroom. And this is when you're doing the transsphenoidal hypophysiectomy with that. You're going to monitor the mustache dressing regularly for any drainage. Check, going to make sure there's no bleeding, no any type of any drainage with that. Check any clear drainage with a urine dipstick for glucose and protein, because if it comes back positive, it's cerebral, could be an indication for a CFS or cerebral spinal fluid leakage from an open connection with the brain. If this happens, the patient is at an increased risk for meningitis.